Will be discussing about aortic stenosis. Aortic stenosis is the most common valvular lesion. Aortic stenosis. It is the most common valvular lesion. Right. And it is more common in males. Means majority are the males. What is the age? Age is basically 6th to 7th decade most of the times if it is not congenital. Right. Now we will be discussing about the etiology, that what are the causes of aortic stenosis. First cause is congenital. What are the congenital reasons? Congenital reason is bicuspid aortic valve or sometimes unicuspid aortic valve. Lesser the number of cusps, more are the chances that they will fuse, and hence aortic stenosis. Degenerative calcific disease. Degenerative disease means it has to do with age. Degenerative disease. Age is the most common factor, that is 6th to 7th decade, right? Then rheumatic fever is also a cause. Rheumatic fever and later on rheumatic heart disease. Then radiation can also be a cause. Radiation to chest for various reasons, for example, for CA of lung or CA of breast. Now, what are the risk factors? Excuse me. What are the risk factors for development of aortic stenosis? The risk factor are same as that of atherosclerosis. What are the risk factors for atherosclerosis? Hypertension, LDL cholesterol elevation, lipoprotein A is an independent risk factor. Again, it is important. Though we have discussed the dyslipidemia as LDL cholesterol, but lipoprotein A is also a part of dyslipidemia, but it is an independent risk factor for atherosclerosis. Independent risk factor for atherosclerosis. Then diabetes mellitus. Diabetes mellitus. Smoking. Then there can be CKD. Then metabolic syndrome. And age, which is most common factor, most important factor, more than 65 years, that is 6th to 7th decade, right? Now what is bicuspid aortic valve? Let us discuss bicuspid aortic valve. Bicuspid aortic valve is an inherited valve defect, and in fact it is most common inherited valve defect. It is autosomal dominant in inheritance, and males are more common than females. The gene involved is notch 1, it is a signaling gene. Notch 1, geta 4, geta 5, and nkx 2.5. These are the genes which are involved. Now coming on to the symptoms. What are the symptoms? Coming on to symptoms. See, aortic stenosis means there is obstruction to left ventricular outflow and the valve area reduces and person becomes symptomatic. Person becomes symptomatic only when valve area has reduced to less than 1 centimeter square. Very important. Though aortic stenosis starts when the valve area starts decreasing less than 2 centimeter square, but person tolerates AS very well and he or she will become symptomatic only when it is a severe disease. What is severe disease? When valve orifice area is less than 1 centimeter square, or on echocardiography when the mean systolic pressure gradient is more than 40 millimeters of mercury. We will discuss that in upcoming later in the lecture, but for now you have to remember that when valve area has reduced to less than 1 centimeter square, then the symptoms start. Before that there are no symptoms. What are the symptoms? There are three cardinal symptoms. There are three cardinal symptoms. What are the three cardinal symptoms of aortic stenosis? First is the exertional dyspnea. Second is the angina pectoris. Third is the exertional syncope. Right. Easy to remember. Dyspnea, angina, and syncope. DAS. DAS. Dyspnea, angina, syncope. And it is exertional. Right. What are the physical findings? On a new page, we will be reading physical findings. What are the physical or clinical findings? These are very important because many named features are there. First is the pulsus parvus at tardus. Pulsus parvus means it has a slow rise. Tardus means it has a delayed peak. Normally pulse is like this. It is a rise and a fall, but in this case the pulse will become like this, slow rise, and peak is also delayed. So this is the pulsus parvus at tardus. There is anacrotic shudder. What is anacrotic shudder? It is carotid thrill which is felt in the carotid arteries. Carotid thrill. Then there is accentuation of A wave. Why there is accentuation of A wave? Because suppose this is the heart, this is the interventricular septum, In AS, the left ventricle thickens. The interventricular septum also thickens. It causes a reduction in the cavity size of left ventricle, as well as it will push the interventricular septum into the right ventricle also in systole. This will cause accentuation of A wave. When atria will contract, I mean right atrium will contract, there will be increased force of contraction required to push the blood into right ventricle. Why? Because there is elevated right ventricular end diastolic pressure. Although there is elevated left ventricular end diastolic pressure also, but for A wave to become more accentuated, we have to you know understand the elevation of RVEDP. So there is also a systolic thrill at the base of the heart, means at right side of sternum. There will be a systolic thrill, right? On auscultation, there will be paradoxical split of S2. There will be paradoxical split of S2. Usually the left sided events they precede the right sided events, but because the left sided events become late in this case, in aortic stenosis, because of the obstruction, the left sided events occur after the right sided events, so the split becomes reversed. There is paradoxical split, means usually there is A2 and then P2, but in AS there will be P2 first and later there will be A2, so it is paradoxical split. And because of heart failure there is S4 also audible. Fourth heart sound is also audible because of LV failure. Why LV failure occurs? Because of LVH, right? So these are the physical findings that we see. Now very important is the murmur of AS. We have to understand completely on auscultation the murmur of AS. Murmur of AS is ejection mid systolic murmur. Ejection mid systolic murmur. We abbreviate it as MSM. Ejection mid systolic murmur starts after S1 and it reaches a peak and ends before aortic valve closure. Right? It starts after S1. Starts after S1. It is low pitched, rough, rasping in character and loudest at the base in the second right intercostal space. Very peculiar. Second right intercostal space. It is low pitched. It is rough. It is low pitched. It is rough. It is second right intercostal space where it is most loud. One thing is the Gallaverdine effect. Gallaverdine effect is when the murmur is radiated downwards to the apex. It is confused with the systolic murmur of the mitral regurgitation, right? So you have to remember Gallaverdine phenomena or Gallaverdine effect, which makes it confused with the systolic murmur of mitral regurgitation. So how about the labs? What will you do in the labs? What are the investigations that we do in the labs? In the lab examination, there is, first of all, we will do the ECG. ECG ECG will show left ventricular hypertrophy or left ventricular strain pattern. Strain means there will be T wave inversion in left sided leads, that is 1 AVL, V5 and V6, right? So this is the ECG finding. Then what are the echo findings? 2D echo is basically done to assess the severity of the disease. We grade the aortic stenosis on echocardiography on the basis of valve area. If the disease is mild or mild AS, means the valve orifice area is 1.5 to 2 centimeter square. Moderate AS means the valve orifice area is 1 to 1.5 centimeter square. Severe AS means valve orifice area is less than 1 centimeter square, that we have already discussed. We have to remember severe AS because severe AS is when the symptoms appear. When the patient becomes symptomatic means he is already having a severe aortic stenosis. Now coming on to the next investigation, that is CT angio. We do CT angio sometimes when there is an uncertainty, right? Because there is angina. Then there are other investigations like cardiac catheterization, which is not required usually to diagnose the patient. It is done basically to treat the patient, to do the valve repair. The valve repair is not done, but to replace the valve we may do cardiac catheterization, right? So what is the treatment of mitral stenosis? What about the treatment of mitral stenosis? See, if it is stage A means there is no disease, but risk factors are present. What we have to do in this case? In this case, basically, we will avoid the physical activity, the strenuous physical activity, and we will try to eliminate the risk factors. We will try to control the BP, means control hypertension, control dyslipidemia, right? Control weight, right? And then uh, we have to treat angina using nitroglycerin, right? We can do RAS blockade also. So these are the risk factors which we have to manage somehow. Though nitroglycerin is the in the treatment, but other things, RAS blockade for hypertension can be carried out, dyslipidemia can be treated, weight can be controlled, right? When it is stage B or C or D, then we have to treat the patient. If it is stage B, which means the patient has moderate disease, means the valve area is 1 to 1.5 centimeter square, but the patient is still asymptomatic. Why asymptomatic? Because symptoms appear only when there is severe disease. How can you manage this patient? This patient can undergo surgery, so we have to do surgical aortic valve replacement, SAVR. See, in aortic stenosis there is no place for repair. repair of the valve. We have to always replace. Now how do you replace is the question. Do you replace it surgically, or you replace it using the conservative methods of not conservative, using the less invasive or less destructive procedures like transaortic valve implantation, TAVI. So uh, either open surgery or transaortic approach. The question is between these two, that what option do we have to choose. So if the patient is able to tolerate surgery, means the patient is asymptomatic, the patient is in stage B, we can do surgical repair, we can do surgical replacement. But if there is stage C and the ejection fraction is more than 50%, the patient is still asymptomatic. In this case also we have to do surgical replacement, right? Ejection fraction is better. Now stage C, but ejection fraction is less than 50%, the patient is obviously asymptomatic, then you can do TAVI also. TAVI means trans aortic valve implantation, and TAVI and SAV are sever, they are both equal, so you can choose either of two. There is no difference in the outcomes, so you can choose any one of these two. And if there is stage D, if there is stage D means it is a severe disease and it is symptomatic. In this case also you can do transaortic or you can do surgical. They both have similar outcomes. So this is about the treatment of mitral treatment of sorry aortic stenosis, right? So this is all about hmm, the aortic stenosis. We have read from right from its etiology, its risk factors, and the symptoms, the grading, investigations, and the treatment. So we will recap it a little. Aortic stenosis, it is most common valvular lesion and most common in males in 6th to 7th decade, which is natural degradation of the valve. Otherwise etiology is congenital also, degenerative disease also, rheumatic fever, and radiation also. What are the risk factors? Same as that of atherosclerosis, that is hypertension, LDL, lipoprotein A, diabetes, smoking, CKD, metabolic syndrome, and age. Bicuspid aortic valve is the most common inherited valve defect, autosomal dominant, and these are the genes involved: notch 1, gata 4. Symptoms only when valve area is less than 1 centimeter square. Cardinal symptoms are three: dyspnea, angina, and syncope, DAS. Physical findings. Physical findings are pulsus parvus et tardus, there is anacrotic shudder, there is accentuation of A wave, there is right of sternum where we can feel the systolic thrill, and on auscultation the heart sound are opposite, there is paradoxical split of second heart sound. S4 is audible, and murmur of AS is also audible, which is mid systolic murmur, ejection mid systolic murmur, starts after S1 in the second right intercostal space, low pitched rough, and there can be galvadin effect which can confuse you with the murmur of mitral regurgitation. What are the lab investigations? ECG will show left ventricular hypertrophy or left ventricular sprain pattern. Echo is usually done to look after the valve and to look how the valve appears and how much is the area of the valve which is still patent, and on the basis of that we can categorize or grade the disease into mild, moderate, and severe categories. Then we can do CT angio if we are uncertain about the angina. Then what is the treatment of aortic stenosis? Staging and then treatment. If the disease is severe, we have to go for TAVI. We can also go for SAVR, but TAVI and SAVR are equal. If the disease is mild, you can go for surgery. Stage C, ejection fraction more than 50%, go for SAVR, surgical replacement. Stage A means there are only risk factors but no disease. In this case, we have to eliminate the risk factors by controlling hypertension, dyslipidemia, weight, and doing RAS blockade. So that is all. I think that is all about the AS. Thank you so much for your patient listening.